Good morning, everybody. It is Corona time. Spread of epidemic is on the rise, country after country, continent after continent. But the race is accelerated for effective management. That included social distancing, isolation, lockdown, then easing of the lockdown, search for efficient treatment. That includes testing, therapies, old and new, and of course, vaccine. It is a public health emergency where no known efficient therapy have been discovered yet. So that's why we are following our instinct in repurposing old drugs. Now, repurposing of hydroxychloroquine and chloroquine comes on top of other drugs. Chloroquine and hydroxychloroquine story goes back hundreds of years, where South Americans discovered that cinchona tree dried bark could be used for headache, pain, and fever. Originally, quinine was purified and was used for malaria. But then in 1945, hydroxychloroquine and chloroquine were synthesized, and in 2020 now they are used or repurposed for COVID-19. Chloroquine and hydroxychloroquine were first used as antimalarial medicine. How does it work? So, when the plasmodium, which is the parasite causing malaria, is injected intravenously by the mosquitoes, they attack red blood cells and they feast on hemoglobin. So they kind of break the hemoglobin into amino acids and heme. They take amino acids because they cannot produce the amino acids themselves. But the heme is toxic, so that's why they polymerize the heme into hemozoin in the plasmodium food vacuole. Now, chloroquine and hydroxychloroquine, and of course quinine, stop this process because it actually accumulates the toxic heme by preventing polymerizing of that heme. So they kill the plasmodium, and that's how they sort of proved to be very, very important for human beings all over the years against malaria. Until the malaria parasites started to get resistance against these drugs. So then we tried to bring different antimalarial medications. We kept following South American wisdom and used them for pain therapy. Chloroquine and hydroxychloroquine were chosen to be among those drugs that have anti-inflammatory and immune modulatory effects. It was discovered over long years of treating such chronic conditions that they have the best safety profile among all other anti-inflammatory and immune modulatory medications. They are the wonder drugs of this group. The wonder drugs are kind of disease-modifying anti-rheumatic drugs as well. So they are used over a wide variety of inflammatory arthritis, including rheumatoid arthritis or ankylosing spondylitis, and also connective tissue disease, including SLE, and very different inflammatory myositis or vasculitis, and even in cancer. How do they work as a disease-modifying anti-rheumatic drugs? Well, they kind of interfere with lysosomal activities. They are basic elements, so they concentrate more in lysosomes, and they kind of inhibit these lysosomal activities. And also they affect membrane stability and also signaling pathway. Most of the inflammatory cascades have been affected by these drugs. And of course, during usage as disease-modifying antiarrhythmic drugs, there were long body of evidence regarding their effect in such disorders. by finally inhibiting cytokine production and modulation of certain co-stimulatory molecules. Well, finally, it was used as an antiviral medicine. How they affect viral disorders? Initially, they interfere with the virus access to the cell or the entry mechanism. They block the receptors, or they kind of inhibit the endosomal ingestion of these viruses. Now, as the virus comes into the cell and goes into the replicating machine, they stop replication of several viruses, including coronaviruses. All these were proven in an in vitro studies. However, well-designed, randomized clinical trials are currently lacking. Believe it or not, these wonder drugs were used in every viral disorder you can think of. Even with HIV, they were used. And you kind of wonder, over this long time, humans are living with HIV. We don't have any clinically proven studies or clinically evidenced study regarding the efficiency of these medications. Usually they do 10 cases or 20 or 30 or 40 cases, then they feel in a hurry to pronounce or popularize their results. No controlled study? Whatever. It was used with HIV, hepatitis, influenza, Ebola virus, Zika virus, rabies, every other virus, with no proven evidence clinically that it might be the one which should be used for viral infection or for COVID-19. Now, quinine was the forerunner of chloroquine. Initially, we had quinine, and the toxicity of quinine was well described to the extent that it's called synchronism, because quinine was taken from the cinchona tree. It affects every organ in the body. Ear, tinnitus, reversible hearing loss, or even impaired hearing. Eyes, retinopathy, blurred vision, photosensitivity, and that effect either ischemic one or direct neurotoxic to the photosensitive receptors, affecting the brain, headache, confusion, convulsions, and coma. Heart, long QT syndrome, anaphylactic shock, hypotension, myocardial failure and death, hypoglycemia, hypokalemia, and of course, finally, toxic myopathy. Now, in order to complete the pharmacodynamics of chloroquine and hydroxychloroquine, we have to talk about the safety profile or toxicity of these medications. Now, these wonder drugs, during their work with chronic disorders, they have been discovered that they have the best safety profile of all disease-modifying anti-rheumatic drugs. So there was no increased risk of severe infection. Of course, it's mostly an autoimmune disorder where the body is turning against its own self. So when you put a brake on this inflammatory process, you kind of cool down the inflammation, and you might not cause severe infection or weakness of resisting bacterial infection, for example. There is very low risk of hepatotoxicity and renal dysfunction. However, the most important and most significant toxicity of hydroxychloroquine and chloroquine is retinopathy or maculopathy. And that could cause a kind of visual field effects or tunnel vision effects or visual impairments. And the only way to check over these effects before it becomes irreversible, something called ocular coherence tomography. I don't know what that. However, this is the most sensitive test that kind of alert the physician or alert the physician against these toxic effects, provided that the patient has got the smart thinking to fastly appreciate any visual defects, even minimal. Also cardiomyopathy and myopathy. And finally, coagulopathy. It might cause thrombocytopenia. So retinopathies, thrombocytopenia, and cardiomyopathy are the main fear when we are receiving or when we are treating patients with such medicine. Now, finally, with pharmacodynamics, you have to talk about contraindications. G6PD deficiency, glucose 6-phosphate dehydrogenase enzyme, is a kind of a housekeeping enzyme that helps the red cells in any oxidative distress. So if it's not there, when you give these oxidative agents, so hemolysis might end up with that. And you can imagine the size of these problems when you know that G6PD deficiency can occur in about 600 or 1,000 millions of people all over the world, and mainly, of course, where in India or South America or in Africa, where malaria was on the rise, and it looks like it's a kind of a genetic disorder that added over the years a kind of a immunity against malaria. So when you have such deficiency and you take such medicine, you are actually endangering your red blood cells into destruction. Well, there are any muscle disorders, of course, any heart disorders, any abnormal EKG or ECG like QT changes that would be exaggerated with chloroquine or hydroxychloroquine. So now finally, chloroquine and hydroxychloroquine positions in the pharmaceutical industry or the pharmacological indications, it is not antiprotozoal anymore because of the resistance resistance of Plasmodium against them. But still, suddenly now it surged as a wonder drug against COVID-19 on the basis that in vitro proof of being antiviral, and also over long time proof as an anti-inflammatory and immunomodulatory therapy. Now, pharmacokinetics means that what happens to the drug when it comes to the body. So what happens to this? When these drugs are absorbed, they are absorbed from gastrointestinal tract. They could be given intravenously. However, people shy away from intravenous because of their retinopathy problems and also any other toxicity. And once they are absorbed, they go to be distributed all over into the site of action, and also the other tissues which store these drugs without any actions. And of course, they are biotransformed or metabolized. They are metabolized in the liver by cytochrome oxidase P450, and the metabolites as well as the non-metabolized drug, they are excreted in urine. Now, the pharmacokinetic profiles of both, there is kind of bioavailability of 0.7 to 0.8 of what's taken. So that's actually a good profile for the drug, because we know that what we are giving, at least 0.8 or 80% of the drugs which we are giving are going to be used by the body. And also, second to that, volume of distribution. They are basic drugs and also water soluble, so that gives them the advantage of being distributed all over very, very huge amount or huge components of tissues, leading to high volume of distribution, then high volume of distribution would affect the onset of action. Now, the onset of action, the volume of distribution were discovered through studies regarding their action as a disease-modifying anti-rheumatic medicines. It was not discovered or it was not studied while they are antimalarial or antiviral. So the high volume of distribution was okay because it leads to because it reflects a long or delayed onset of action, because and then this delayed onset of action wouldn't affect the disease because it's a chronic disorder. So there is a luxury of the patient to wait for 1 or 2 weeks until the medicine takes its own effect. And also the very long terminal half-life, and that means that their action lingers in the body after they have been stopped. And again, during chronic disorders, there is no problem with that. Metabolized in the liver by cytochrome oxidase P450, nearly 30%, and the rest will be excreted through the renal clearance. So now we know that it is used for COVID-19, being antiviral as well as anti-inflammatory medicine. However, we have to confess that repurposing of COVID-19, there is a knowledge gaps which begs the presence of research agenda regarding certain factors. Now, it is one dose fits all. Believe it or not. There is no dose efficacy or dose safety relationship at all. There is no change of doses according to the efficacy or according to safety. It's one dose fits all. And also there is no dosage for kidney failure. We don't know what happens or what is the required dose with kidney failure, because kidney would decrease release or excretion of the metabolites as well as of the drug itself. So it might cause increased toxicity. We know that, but we don't know to what extent we decrease the dose with kidney failure. And also, while cytochrome oxidase P450 activity is going to be affected by many other factors, we don't know what's the relationship with this to bioavailability of the drugs. That's why most of the chloroquine and hydroxychloroquine medications could be used with a macrolide, that an inhibitor of CYP450, but we don't know the exact effect on bioavailability. Also, there are two isomers, and we don't know the relationship between risk and benefit of each one. So we don't know the profile, risk to benefit profile of each enantiomers, whether we need to isolate one or the other. Cardiovascular events, again, were not discussed. The only thing where during these chronic disorders management with these two wonder drugs, that there is a long QT syndrome, but we don't exactly know what happens with cardiovascular events or thromboembolic events, and also the mortality of these drugs were not studied. Finally, retinopathy. What are the risk factors of retinopathy? Again, during chronic disorders management, we found that more than 5 milligrams per kilo is increased risk, has increased the risk for retinopathy. More than 5 years of management or treating of this with this medicine would increase retinopathy, and also any renal disorders or liver disorders might cause prolongation of the medicine and higher retinopathy. But still, we don't have any clinical studies regarding these retinopathy risk factors. Now, with this knowledge gap and this research agenda on our mind, we found that these wonder drugs have been used in chemoprophylaxis against COVID-19. Though the drug is untested, benefits are unknown and risk not negligible, especially at the scale of such use. Usage of these drugs have been popularized by WHO on one condition, that it is used in clinical studies. It cannot be used routinely or for any patient. It has to be restricted for clinical studies with certain exceptions. So we don't understand why the Indian Council of Medical Research had put this protocol of chemoprophylaxis of hydroxychloroquine against COVID-19 into action. Nor we understand the President of the United States of America, where when he promoted the usage of hydroxychloroquine against COVID-19, which as a matter of fact had made a surge of prescriptions of hydroxychloroquine in the United States in the month following his announcement of these drugs. All that had led the World Health Organization to prepare for a solidarity trial, which is a very, very ambitious trial. All over the world, a clinical trial of usage of all antiviral drugs, including hydroxychloroquine and chloroquine, and looking into the clinical outcome of these drugs. And also, they had announced that off-label use of these medications, hydroxychloroquine and chloroquine, should be only in clinical studies or on a case-by-case basis, including that the patient is well informed and consented for that. And on the other side, you have to avoid stockpiling and shortage of approved medicine for other diseases. So we had created shortage of hydroxychloroquine in India, in Egypt, and most of the countries, including America, because of starting to popularize this medicine in order to treat COVID-19 on unproven basis. So based on evidence from laboratory, animal, and clinical studies, the following treatment options were selected. All antiviral drugs and hydroxychloroquine were selected all over the world. And they started to do that. However, the Lancet had issued a multinational registry analysis on the 22nd of March. The Lancet had, for the first time in history, put the effect of hydroxychloroquine and chloroquine on the test. So data from 671 hospitals in 6 continents, starting from December 20th, 2019 to April 14th, 2020. And all these patients were RT-PCR positive for SARS-CoV-2. They looked at the main outcomes as in-hospital mortality, de novo ventricular arrhythmias, ventricular tachycardia, sustained or non-sustained, as well as ventricular fibrillation. Alas, this was the first study, which means a real clinical insight into the action of these wonder drugs. It is a large multinational real-world analysis. However, alas, chloroquine and hydroxychloroquine in COVID-19, the verdict is out. Guilty as charged. No benefit of these medications. No benefit of chloroquine or hydroxychloroquine in COVID-19. Not only that, but also there is significant rise of hospital mortality, ventricular tachycardia, and ventricular fibrillation. Wow. Wow. The verdict is out. Guilty as charged. However, we should note here that this study were not really complete because they did not include prophylactic treatment. They didn't include prophylactic treatment. We don't know why they didn't do that. And we didn't know whether India and Egypt and other countries where prophylactic hydroxychloroquine is used are in this study or not. However, on one side, they didn't include prophylactic treatment. On the other side, they did not address the elephant in the room, retinopathy or coagulopathy. They didn't look into changes of visual fields or changes for platelets. Now we have 3 cases that we need to discuss, and we need to start actually discussing that. Case 1. There was an Egyptian doctor who worked in an isolation hospital. He started his work day 1, and then at day 7, he developed coma for 12 hours. And then when he woke up from this coma, when he recovered, he was blind. Definitely, he was not blind before that. He was a doctor working in a hospital. So what made him to be that blind? Did he receive hydroxychloroquine as prophylactic treatment? We don't know, but we need to answer this question. That's a very important one. Now, case 2, there was a drive of circa 30 miles by the Prime Minister advisor as a vision test. So we again ask this question. He is a smart person. So he had noticed some problems with his visual fields. So he went on a short drive to check his visual test. Again, had he received prophylactic hydroxychloroquine? Again, we don't know that. We should answer these questions. The third case, which we need to discuss, in Egypt, there is a large scale routine hydroxychloroquine implementation, even with self-isolation program. There is self-isolation program in Egypt now as a kind of a late development by the government against COVID-19. And then the patients were issued hydroxychloroquine to take home. We want to know, were these patients consented for that or not? Were these patients checked for contraindication or not? Were these patients followed for toxicity or not? Now, finally, retinopathy is a most significant effect of hydroxychloroquine and chloroquine. So now the eyesight will be affected by hydroxychloroquine and chloroquine. But then people might say as well that coronavirus itself can affect eyesight. We don't know that. Though the Prime Minister, Boris Johnson, said on the point about eyesight, I'm finding I have to wear spectacles for the first time in years. I don't know what this proves. Does this prove that he also had prophylactic or therapeutic hydroxychloroquine? Or well, coronavirus itself, which attacked the Prime Minister, might have caused him some sort of eyesight problems. However, leading Moorfield Eye Hospital in London said such cases were rare and more evidence was needed in order to prove that COVID-19 can cause eyesight problems. The Royal National Institute for Blind People said sudden change in vision is a reason to seek immediate medical advice from an optometrist or NHS 111. So, again, the jury is still out for coronavirus and eyesight problems. However, it is in for hydroxychloroquine and eyesight problems. So much so that as the verdict is out, guilty as charged, so Solidarity Clinical Trial for COVID-19 treatments by World Health Organization put a temporary pause on hydroxychloroquine arm until reviewed by Data Safety Monitoring Board. So, end of story. That ends the story of hydroxychloroquine and chloroquine in COVID-19. That's it. No more hydroxychloroquine or chloroquine for COVID-19. Now, there is one case in America that needs to be mentioned here. We said that as an antiprotozoal, hydroxychloroquine went into disfavor because of the resistance developed by Plasmodium against them. However, for fishish syndrome or white spot syndrome for fish in a tank is still treated by hydroxychloroquine. So these wonder drugs are still able to be antiprotozoal for fish or for fish tanks. And what happened when the President of the United States talked about hydroxychloroquine? A couple used the hydroxychloroquine for fish. They used it themselves. One died and the other was admitted to intensive care unit. Again, the verdict is out. No more usage of hydroxychloroquine or chloroquine as an antiviral or an antiprotozoal. Chloroquine, hydroxychloroquine, final position is an anti-inflammatory, immune modulatory drugs for chronic disorders, especially autoimmune disorders and connective tissue disorders. No more antiviral, no more antiprotozoal. Verdict is out. Guilty as charged, Your Honor. Not to be used anymore. So probably, now when we say guilty, who was guilty? Is it the patient who received hydroxychloroquine, or the doctor who wrote hydroxychloroquine, or the president who promoted hydroxychloroquine, or the other doctors who did not stop the president from doing what he was doing? We need to look into that, especially during epidemics. Doctors should have very, very accurate statements about all aspects of COVID-19. Thank you.